So the clinical relevance is compelling. So in a double-blind controlled trial, 28 adults with a mean age of 75, researchers tested 4 different doses of rosemary powder in relation to cognitive performance. And here's what's remarkable. The lowest dose of 750 milligrams, just as under half a teaspoon of dried rosemary, significantly improved cognitive performance compared to placebo. But here's the twist. The highest dose of 6,000 milligrams in that study actually impaired performance, thus showing us that more isn't always better when it comes to herbal medicine. And additional studies to support these findings with the Japanese researchers found that men consuming just 1 gram of rosemary daily experience improved mental functions and energy performance, better sleep quality, and reduced daytime sleepiness. In another study, night shift nurses who added just 1 drop of rosemary essential oil to their masks. So if somebody's still using masks out there, this is something that you could definitely do. It actually decreased sleepiness when they were doing their shifts in the hospital and increased alertness compared to controls. So what I love about rosemary is its versatility. The essential oils are readily absorbed through your skin, through inhalation, and through ingestion. You can easily incorporate that therapeutic 750 milligram dose in your daily cooking. So that's less than half a teaspoon. So that's how easy it is. You can also use it as tea or taking 1/2 to 1 teaspoon of dried herbs per cup, up to 3 cups daily. And those who prefers tinctures, you can use 2 to 4 milliliters 3 times daily. It's even effective topically and through aromatherapy. However, safety is crucial. Never ingest isolated essential oils as they can cause gastric irritation. So this is a lesson for our patients who thinks that the topical essential oils can also be ingested. So it's not. It can also cause kidney damage and even seizures. So limited topical and inhalation applications to not more than 3 times per day. And if you're taking blood thinners, avoid rosemary as it may inhibit platelet aggregation as well. So the long-term effects of chronic high dose still remains unknown. So the takeaway message here is rosemary offers a safe, natural, and delicious way to support cognitive health, which we're going to be talking about today also, with solid scientific evidence. The effective dose is easily achievable through normal culinary use, making it one of the most accessible cognitive enhancers available. So whether you're 75 years old looking to maintain mental sharpness or a busy professional needing better focus and alertness, rosemary deserves a place in your daily routine. Remember, sometimes the most powerful medicine is sitting right in your spice cabinet. So thank you for our Andrew tip of the week.
Okay. Thank you, Dr. Nario. So welcome everybody, and we're really happy to have our speaker this week, Sharon Hausman-Cohen. Those of you that have been in the longevity anti-aging world, that she's no stranger to any of us, and it's an honor to have her here. Just a little bit, since you're not familiar with us, Dr. Hausman-Cohen, Dr. Nario is taking Andrew Weil's integrative medicine course at the University of Arizona in Tucson. And we pick his brain every week and get a tip of the week so that we don't have to go there and also spend the money through the tuition. So we're living vicariously through him. So one of these days I'm going to aggregate all of them, because he's been there. You've been there about a year now, right?
Not yet. Half a year.
Okay. And I unfortunately muted you, Dr. Hausman, but was clicking somebody in. So if you could unmute yourself. And about a half a year?
Almost, yeah.
Taking any tests? Are you passing?
I hope I can last longer until they see me out information. We have a mole in here, and he's giving out information.
Yeah, we don't want you to. Yeah, we don't want you to embarrass us. So, so it's a little bit after 5, and so thank you for being with us. We're really honored. For a lot of us, you don't really even need an introduction. But Dr. Hausman-Cohen is nationally recognized expert in the field of genomics with a career dedicated to making genomic data clinically actionable Her research and publications focus on improving outcomes in cognitive decline, treatment-resistant mental health conditions, and autism by integrating genomic insights into personal care. She's the chief medical officer and co-founder of Intellex DNA. I hope I said that right. An evidence-based genomics platform designed to help physicians identify and address underlying genetic contributors to chronic disease and health optimization. She co-authors numerous peer-reviewed articles and textbook chapters on clinical applications of genomics in integrative and functional medicine. And if you go to any major anti-aging, A4M, AMMG, any of the other groups, she's almost universally there. And I've heard her many times. She's board certified in family medicine, and now I lost the rest of it. So why don't you
integrative
pick it up
medicine.
from there, okay?
Yes, I will be happy to. Board certified in family medicine and integrative medicine, and I've actually taught at the Andrew Weil Fellowship a number of years ago. So,
Nice.
so what we're going to talk about today is a topic that I think is really important. We're going to talk about beyond pharmacogenomics, being able to address the root causes of depression and anxiety. So I'm going to jump right in. And when you think about a patient with depression or anxiety, really there's not a lot of different tools that you can use to address. And you guys should be able to see my screen, right? Hopefully.
Yep, we see it.
Okay, perfect. Blood tests aren't really very helpful because of the blood-brain barrier. You might use your urine organic acid testing or some metabolite testing, but really there's nothing that gives you a lot of insight to the root cause. And genomics has that potential. Now, pharmacogenomics came out really got established under Obama when he passed the Precision Medicine Initiative and said we need to be using pharmacogenomics to help make medical decisions and for oncology genomics. And then the next phase of genomics was going to be looking at root cause genomics. And that's where my area of research has taken off and has been involved in, what I've been involved in. It's important to understand that pharmacogenomics is not about looking at the root cause. Pharmacogenomics is understanding medication metabolism. Root cause clinical genomics is a whole different field. But let's talk for a minute why I say that pharmacogenomics alone is an inadequate tool. And the reason is because it will identify gene-drug interactions. It will help you understand the metabolism of medicines. Somebody who is a rapid metabolizer of fluoxetine is going to need a higher dose. Somebody who can't metabolize a particular drug is going to need a lower dose. But what pharmacogenomics does not tell you is the root cause of why are they having the depression or why are they having the anxiety. And that's the key piece of the puzzle. So in general, pharmacogenomics will talk about serotonin drug metabolism, norepinephrine drug, dopamine drug metabolism, but it's assuming that neurotransmitter imbalance is the root cause of the depression or the anxiety. And so what if that wasn't the cause? Let me show you this study from 2013 where they added pharmacogenomics to usual care. And what you will find is that only 20%, so here in the orange, you're going to see remission, which means getting well. Even with pharmacogenomics, only 20% of individuals were well at 10 weeks. Now, that was definitely better than the 9% in the usual care group. But what does it really mean? It means that 80% of people didn't get well. And even if you look at people who got 50% better, which is what response is, it still was less than half of people were 50% better, even when you used pharmacogenomics. So what were they missing? And then this is another trial that, just in case you go, well, that was 2013, maybe it's gotten better. It hasn't. This was a trial in 2022 looking at treatment-resistant patients and even more detailed pharmacogenomics, and still only 16% achieved remission at 8 weeks versus 9% of treatment as usual. So what was going on? Well, as you guys know, because you're in the integrative world, you have to look at root causes in order to get someone well. And there is not just one root cause for chronic diseases, and depression and anxiety are included in that. So these are just a couple of different articles And you can see markers of oxidative stress on average were almost 5 times higher in individuals with depression compared to controls. Many people with depression and anxiety have elevated cortisol or elevated adrenaline, and that contributes to the depression. Being deficient in nutrients like zinc, vitamin C, magnesium, B6, they're all important for depression because it relates to making neurotransmitters. And inflammation has to do with everything, every chronic disease. Now, all of these relate to genomic variants. So when we look at the genomic variants that in the literature, so documented in the literature, have been associated with depression, there are some that relate to serotonin production and regulation, but also ones that relate to brain cortisol regulation, methylation factors, the ability to make something called tetrahydrobiopterin, which we're going to talk about, and on and on and on. Everything from gut permeability to growth factors to toxins and, again, inflammation. When you look at the genomic variants contributing to anxiety, we have a lot of overlap, still serotonin production and regulation. But there's a really important gene for anxiety that causes you to have too much histamine in your brain. And histamine will make you feel like, just like antihistamines make you feel sleepy, histamine will make you feel more awake and panicky. And too much orexin, which is the opposite of melatonin. Orexin is your wakefulness hormone. There are genes that are receptors for where adrenaline binds. If you bind adrenaline 10 times more tightly, you're going to feel anxious. There's things that relate to thyroid conversion in the brain, how we process sugar, again, glutamate, dopamine related pathways, and inflammation. Okay, so let's say you have a genomic map of your patient and you know that somebody has a bunch of root causes. That's not enough for you to actually help them. And again, this has been where my area of research has focused on. Once you have identified root causes of depression or anxiety, you have to know how to respond to them. So to be useful, a genomics tool for mental health has to identify the contributing genomic factors, but it also has to offer various solutions that are genomically targeted to an individual's etiology. So if you think about how many things there are in the literature that have efficacy for improving outcomes in someone with mental health concerns, magnesium, vitamin D, B vitamins, lion's mane, polyphenols, curcumin and resveratrol and liothyronine and adaptogens and dozens more. The question is, patients don't want just trial and error. How can you use their DNA so that you can get it right the first time? So what we're going to do now is I'm going to talk to you about the top 10 genes that are associated with mental health. And that's going to give you an idea of how genomics would improve your insight for patients and your treatment. So the number one gene in mental health, in my opinion, for depression and anxiety, because it has the highest odds ratios, the highest likelihood of contributing towards this, is a gene called HTR1A. And anytime you see HTR, that happens to do with the serotonin or the tryptophan pathways. But HTR1A, I like to call the faulty serotonin thermostat. It is expressed on serotonergic neurons, and what it does is it's a regulator. It's an autoreceptor, and we want to be able to judge how much serotonin we have so we can stop making it when we have enough. And with this particular autoreceptor being overactive, you think you have a lot more than you have, so you stop making it. Imagine if your thermostat in your house was broken and the thermostat said it was 70, but it was really 40. Well, if the thermostat is reading 70, it's not going to turn on the heat. And so the sensor is broken. And so then the downstream effects are the sequelae of not turning on the heat, or in the case of HTR1A, not turning on serotonin production. What I mean by an autoreceptor is that there are both pre and postsynaptic receptors. This is a presynaptic autoreceptor that is, again, helping to regulate and measure serotonin. It is the postsynaptic receptors that transmit the serotonin effects. So the reason HTR1A is such an important gene variant is it has the highest odds ratio in the literature for both depression and anxiety. 2 copies of HTR1A, the HTR1A variant associated with depression and anxiety, is associated with 2.8 times the risk, or 182 times the risk of anxiety and depression, both. 2 copies is found in 17% of the population. It is still a very high risk, even with 1 copy. And every gene variant gives kind of its own phenotype, its own presentation. This particular gene variant is also seen in higher amounts in people who have more fear, bipolar disorder, increased risk of suicide, more severe depression, and a slower and reduced response to SSRIs. Now, this last one's really important because we were all taught that SSRIs take 8 to 10 weeks to work. Well, why? Well, it's because this is the most common gene variant for depression and anxiety. It's not that they really take 8 to 10 weeks to work to recycle serotonin. It's that most people with depression and anxiety that have a serotonergic component don't have enough serotonin. So you can't recycle it till you start to rebuild it. HTR1A is also interesting because it's associated with a blunted cortisol response to acute stress. What this means is that during times of stress, you actually want to have your cortisol go up a little and you want to get out of the stress. But people with this particular gene variant find it more difficult to activate their cortisol and their fight or flight system, so they stay in a bad situation. Think about how many of your depressed patients tend to have apathy and difficult initiating activity. This is partially because of HTR1A. Now, the reason patients with HTR1A have a slower and less robust response to antidepressants is you can't recycle something you don't have. So what do you do for individuals with HTR1A? Well, the first thing you have to do is to push the serotonin synthesis pathways, since it's a dysregulated sensor. And so how do you do that? Well, there's a lot of different ways, but we know that giving things like saffron, which can increase serotonin synthesis, giving 5-HTP, which is the precursor to serotonin. In some people, you might use SAMe, giving cofactors like vitamin D, or very specific probiotics, Lactobacilli helveticus and Bifidolongum, all increase gut synthesis of serotonin. And then, of course, a 10,000 lux light. And so you'll see there are ways of addressing this gene and every gene in our body using diet, lifestyle, supplements, and medications. So in terms of medications, we know that SSRIs are actually less effective than SNRIs for this particular gene variant. And again, I'll be happy to answer questions in more detail afterwards. Let's take a mini case. So this is Candy. Candy is 64 years old. She has severe depression and seasonal affective disorder since she was a teen. And her depression's poorly controlled with 150 milligrams of Zoloft. She actually is pretty flattened affect. She hates Christmas and winter holidays, which is really bothersome to her family because at this point she's a grandmother of 3 grandchildren. She also has chronic gut issues, diarrhea, prone IBS. And in her genomics, she's got 2 copies of this HTR1A, but she also has 2 copies of MTHFR. So some of you may know that one. It's the one that allows you to turn folate into methylfolate, which is the form of folate that can cross the blood-brain barrier. She also has SNPs relating to low zinc. Well, zinc is the cofactor for serotonin. She also has SNPs relating to inability to recycle vitamin C. Well, vitamin C is the cofactor for norepinephrine. And she has SNPs relating to gut histamine intolerance, which explains a lot of her gut stuff. So what did we do for Candy? Well, once we got her genomics, it was the easiest fix. I mean, she's literally been struggling with this for over 45 years. We gave her methylfolate to address MTHFR. We fixed her gut with glutamate. It says L-glutamate, but it should say L-glutamine, and made her aware of high histamine foods and gave her DAO. We gave her vitamin C and zinc so she could make, and 5-HTP, so she could help make norepinephrine and serotonin. The mood support product we gave her had particular bacteria and saffron to increase her serotonin synthesis. And we started lowering her sertraline to help with the fatigue. Kathy did absolutely great. She is now on 50 milligrams of sertraline and the mood support product and the methylfolate and the nutrients. And she loves Christmas now, and her gut is fine as well. Let's take SNP number 2. IL-1 beta. So anytime you see a 1 or an alpha, TNF alpha, IL-1 alpha, IL-1 beta, those are really important pathways. We tend to put the lower numbers on some of the more important pathways. But IL-1 beta causes elevated interleukin 1 beta, and interleukin 1 beta causes systemic inflammation. It spreads inflammation from anywhere in the body, throughout the body, including into the brain, and will create a brain on fire. So if you have somebody who has heart surgery or has a dental infection, this will create inflammation in their body that will go to their brain. But there are also about 8% of the population that make very high levels of IL-1 beta. And then there's another 15% of the population that make moderately high levels of IL-1 beta that predispose them naturally, as if they were sick or had just had surgery, to depression, to bipolar, to autism, to post-traumatic epilepsy, brain swelling, after TBIs, for example, and cognitive decline. So this particular gene variant of that makes IL-1 beta goes up causes 3 times the risk of autism, even with 1 copy. But it also causes a significant increase of depression. And that is particularly important in seniors because seniors have more systemic tissue damage in their body that's going to augment that IL-1 beta. So let's talk about why IL-1 beta is so bad and how does it transmit inflammatory signals to the brain. One of the really fun things is when you study genomics, you're going to learn pathophysiology in a whole new way. So if I could see your hands, I'd say, how many of you have ever ordered Resolvins or seen the use of Resolvins? And probably a lot of you have said, I have. Well, what Resolvins do is they turn off inflammasomes. Well, what is an inflammasome? Well, an inflammasome is the endpoint that transmits inflammation from IL-1 beta. So IL-1 beta activates these things called NLRP3 inflammasomes. And it causes then an inflammatory signal that can cross the brain. And it's associated with, again, all kinds of mental health issues, but failure to achieve remission in depression. Why? None of our antidepressants that we prescribe really address brain inflammation. And just so you know, for those of you dealing with seniors, amyloid will trigger the activation of inflammasomes. For those of you dealing with Lyme or mold patients, viruses, bacteria, fungi will trigger the activation of inflammasomes. So there's a lot of things that trigger it. Now, what do you do for someone with high IL-1 beta? I made this chart to show you that there's so many ways you can address IL-1 beta. And how you address it is going to depend on what's going on. You can use Resolvins, you can use omega-3s, you can use sulforaphane, resveratrol, apigenin, luteolin, quercetin, and you might have to decide, well, for example, sulforaphane has great results in autism and ADHD and schizophrenia and pain and a little bit in depression, but apigenin has better studies in anxiety and sleep. So it may depend on what's going on, which intervention you choose. Let's talk about SNP number 3. GPR50. So even though GPR50 stands for a G protein, I like to think of it not a good pairing, high cortisol and low melatonin. So GPR50 increases your activation of your HPA axis, makes your cortisol levels go a little bit crazy, and at the same time lowers melatonin signaling. This leads to patients feeling stressed and depressed and has more significant effects in women. You guys can be thinking about why a gene might have more effects in women, but it's an overactive gene that has 1.77 times the risk of depression in women. So before I give you the answer as to why it has more effects on women, I'm going to ask you, have you ever heard of beta-arrestin? I had not before I started studying genomics, but beta-arrestin has the job of regulating our beta-adrenergic receptor function. It keeps our adrenaline response from getting out of control. So its goal is to help arrest the fear and anxiety behaviors. So GPR50 lowers your beta-arrestin. So you no longer have the ability to arrest or stop those anxiety behaviors. Now, if you've ever given a patient steroids and had them call you and say, I can't sleep and I feel crazy and I feel stressed and I feel anxious, that's GPR 50. That's an overactive GPR 50. But for patients with GPR 50 variants, they can get that corticosteroid like negative effects on their HPA axis without even taking any steroids, because steroids will also cause that same lowering of the beta arrestin. Now, what about the melatonin? Well, melatonin, MLT up here in purple, normally binds the melatonin 1 receptor. However, when you have too much of this GPR50 protein, it hogs that melatonin receptor. And by hogging the melatonin receptor, you can't get melatonin signaling, so you can't sleep well. GPR50 also blocks beta arrestin from doing what it needs to do. So GPR50 does not directly bind the melatonin, it binds the melatonin receptor. Oh, just in case you were wondering about why it works more in women, it's an overactive gene, and women, it's on the X chromosome. So women already have higher GPR50 pathways to start with. So then you throw in variants, they can have 2 variants, men only can have 1 variant. Okay, what can we do about this? Well, the best way to address this is to look for ways that you can lower those patients' anxiety by addressing their cortisol. Again, think about all the medications we have in our prescription armamentarium for anxiety and depression. Benzodiazepines, which work on GABA, things that work on serotonin, some things that work on, dopamine as well, and norepinephrine, but we don't have anything that works to help to temper down the cortisol pathway. This is a study of ashwagandha, and if you guys are going to learn one herbal tonight, let's have it be ashwagandha, because it is an amazing study. So this here is given 300 milligrams of ashwagandha, and the usual dose is 300 to 500 milligrams twice a day for 6 weeks. And it started to separate from placebo very early on, usually within a few days. The perceived stress score went down 44%. That's what PSS is in the ashwagandha group versus 5% in the usual care placebo group. The global health questionnaire went down 72%. The depression and anxiety subscale of the global health questionnaire went down 72%, and cortisol levels went down almost 30%. The p-values in this study were less than 0.0001. That means it was 99.99% likely that the anxiety was being improved by ashwagandha. That is much better than the p-values for sertraline. Another option is Relora, and this was a study of athletes that were stressed and anxious, and you'll see that depression went down 20% in the people who got Relora, stress went down 11%, fatigue improved 31% because it improved sleep, and their vigor improved 18%. So Relora, which is Magnolia officinalis and philodendron combined, is another option. Okay, SNP number 4. Adora 2A. I like to think of this as adore your caffeine. It doesn't adore you. Adora 2A creates caffeine-induced anxiety and panic. 2 copies, 16% of the population, and there's a 50% increased risk in panic and agoraphobia. But also, and if someone uses any kind of a stimulant, it will create anxiety. And it also increases the risk of seizures and tics. Why? Well, this is a low functioning adenosine 2A receptor, and caffeine blocks the adenosine 2A receptors. So it's going to make it worse, and you're going to get more panic or anxiety. So if you're trying to think what the adenosine 2A receptor is, always think coffee. What happens if someone has 10 cups of coffee? Well, if you have 2 copies of adenosine of the Adora 2A, you can get that effect without any coffee or with even 1 or 2 cups. Now, adenosine is also naturally sleep promoting. So people who have these gene variants have 40% higher risk of sleep disturbances and problems with concentration as well. Now, Adora 2A regulates not just the adenosine-related neurotransmission, but it also relates to your glutamatergic pathways. And again, if you don't quite yet have a picture of glutamate, think of glutamate as fire, 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 the brain that's constantly firing. And so glutamate's important because you need it for cell communication and synaptic plasticity, but too much glutamate creates excessive toxic buildup, and it also creates kind of panic and OCD type symptoms. High glutamate are the people who can't get the thoughts stuck out of their head. Also, things like nail biting or hair picking or pulling. Okay. Adenosine. So when we look at the behaviors affected by the adenosine 2A receptor, sleep, movement, anxiety, cognition, memory, tics, and seizures. So how do we address it? Well, let's look at the different neurotransmitters affected. Low levels lead to high glutamate, low GABA, high dopamine, and lower BDNF. So those are our targets. So hopefully you're getting an idea of how genomics works. We figure out what does the gene do, what does the gene variant do, and how you can then modulate it. So for people who have this variant, we want to lower their glutamate, we want to raise their GABA, we want to lower their dopamine. Let me do a little case of anxious Alan. So Alan is a 25-year-old male who comes in with the main concern of anxiety. He tells me he's catastrophizing thoughts. He's got tachycardia with breathing difficulties. He's hypervigilant. He's got some gut issues. When I do a diet history, he tends to drink energy drinks very often because he's feeling tired. Lab value does show significant B12 deficiency and vitamin D deficiency. So of course we have to fix that. But of course for Alan, when you see his genomics, he had a lot of different things going on, and we're going to focus on the ADORA 2A pathway. The combination of him having high adrenaline, so this ADRB2 is the adrenaline receptor, and high lower ADORA 2A that creates the panic in response to caffeine was a bad idea. So he also has increased TNF alpha and IL-1 beta, which both can contribute to mood. What can we do to lower his ADORA 2A receptor activity? I'm sorry, we want to increase his ADORA 2A receptor activity and binding. We can give DHA, which is from omega-3s. We can give genistein. We can give theanine. So theanine is not to increase ADORA 2A, but is to increases GABA and lower glutamate, and then we can give NAC to lower glutamate. Because anxious Alan was a nail biter, I chose NAC as one of the interventions, but we also chose theanine to kind of help him feel calm. Talking to the patients with these gene variants about their diet is important. This is just a comparison of how much caffeine is in different drinks, and you'll get caffeine-induced anxiety with ADORA 2A people with 100 to 150 milligrams. If you get one latte, you can have 170 milligrams right with a latte. If you get a grande blonde roast from Starbucks, it's 360 milligrams. And even decaf can contain up to 50 milligrams a cup. So a better choice would be black tea or green tea, which will give them, more of that 30 to 50. He was drinking Red Bull, but a number of them a day, which had 80 milligrams per can. And sometimes he got energy drinks that had even more. Now, this is a really important gene variant that we just had a publication accepted on, involved in treatment-resistant depression, treatment-resistant mental health conditions. And this paper will come out literally in a week or two in Frontiers on Neuroscience. And this is called GCH1, guanosine triphosphate cyclohydrolase 1. And I think of it as the little known big sister to MTHFR. Again, I would anticipate that all of you have heard about MTHFR. Some people call it the mother-father gene, the mother this gene, whatever, but it's the gene that allows you to make methylfolate. And you know that without it, you can't make serotonin, norepinephrine, and dopamine. But without GCH1, you can't make any of those, and you can't make nitric oxide. So this increases the risk of depression, but also can increase the risk of all kinds of mental health. In the publication we're about to publish, we have people who had real significant behavioral issues with head banging and behavioral issues. We had people with PMDD, we had people with severe anxiety, etc., as well as autism and depression. We're going to do a mini case of Jasmine. Jasmine is a 13-year-old with tremendous anxiety and a little bit of depression as well since she was young. She's been on homebound for a good part of every school year since second grade, doesn't go to clubs or parties, has been to psychiatrists, multiple practitioners, both integrative and classically trained. They've given her fluoxetine, they've given her all kinds of things, all kinds of counseling. But really, her problem is she's got 2 copies of GCH1, which is found in 4% of the population. So she can't make serotonin, she can't make norepinephrine, she can't make dopamine, and she can't make endothelial nitric oxide, which allows blood flow to the brain. She also has SNPs that lead to lower GABA signaling that are only found in 2% of the population, and a gene variant that lowers her ability to absorb zinc. But BH4, tetrahydrobiopterin, was absolutely key for Jasmine. What do you do for someone with GCH1? You're going to give them not prescription Kuvan PKU doses of BH4. Just in case you don't realize what BH4 is, it's what they give for people who have phenylketonuria. It's Kuvan or sapropterin. But you're going to give very low dose, about a 20th of what you would give to a person with a PKU. And this will help to overcome that SNP. You can get this over the counter, and you can also in low dose, and you can also get it from compounding pharmacies. You can also do other things. If they only have 1 copy, you can give things like resveratrol to increase the transcription of BH4 and endothelial nitric oxide. You can do sauna and vigorous exercise therapy. Ultimately, Jasmine joined the track team, and that also helped her. But for Jasmine, really the tetrahydrobiopterin was so key. She is now 100% anxiety free. She has not missed one day of school. And she's joined a track team, started to sleep over at friends, and is told her father to thank me. And actually, her father did a recording that I can tell you if you want to see about how she got completely well by using precision medicine. So I'm going to stop here to take some time for questions because if we go through all the top 10 gene variants, we won't quite have enough time for questions. But what I want to talk, just kind of end with is pharmacogenomics is really useful for dosing and metabolism, but it doesn't help you understand the etiology. When you look at a gene variant or a SNP, a single nucleotide polymorphism, that have demonstrated odds ratios for anxiety and depression. So this one SNP might increase at 70%. This SNP might increase at 150%. One SNP might increase at 200%. When you look at those and map them out, and you take those top 5 or 6 different gene variants that somebody has that relate either directly to anxiety, depression, or to their inflammatory pathways, their detox pathways, their nutrient pathways, their gut health, you can come up with a precision treatment plan that allows you to get more rapid outcomes, dramatically better than trial and error. Just like a lab test, genomics is only useful to use if you know how to modify or address these SNPs. And that is where Intellix DNA, that is where using a clinical decision support tool makes sense, because you have to have the ability to address the SNPs. When gene function's understood, then you can use it, distill what you learned in your everyday practice. And so the era of individual therapeutics is here. Today we talked about anxiety and depression, but you can use it for cognition. This is the genomics is being used by Dr. Dale Bredesen in his current research to help improve outcomes in cognitive decline. You can use this for complex pediatrics like autism or PANDAS or PANS. You can use it for environmental illness. The same principles apply. You look at the genomics, understand what root causes that patient is struggling with and why they might have some particular symptoms, and then you address them. So I'm going to leave out not only my email, but I'm going to take questions, but I do want to give you this QR code. And if you have, it looks like the QR code got slightly cut off. So I'm going to give you an email. I'm going to have to go and fix the QR code. I don't know if it'll scan properly because it looks like it got trimmed, but you can go to Dr. Clearfield. Can I just say the website at this point
Um,
or questions?
okay, anybody have any questions? I don't really see anything in the chat. But
There's a
Dr.
couple. Let me
Neri,
look and
got
see.
anything online? You
Let
there,
me go
Dr.
to the chat.
Neri? Got anything online?
Go
Yes.
back.
Where do you get the BH4 and what's the trade name for it? Tetrahydrobiopterin?
Pharmacogenomic brands that are out there that are used by conventional medicine. And even them, they vouch for these tests to be useless. So, because for the reason that they've tried to use the medications that were actually recommended from that test, and they didn't see any results from it. So that's why they definitely are missing a key point that you're actually putting out there that's very important, that in the integrative approach of genomics, that you need to address the other issues such as inflammation, such as vitamin nutrient deficiencies. So I think that's what your company brings to this discussion.
And I think that there's even a finer nuance. So, for example, one kind of inflammation is CCL2. It's a very destructive type of inflammation. And the best way to lower CCL2 is palmitoyl ethanolamide, PEA. Now, only 8% of the population has two copies of CCL2, but for that 8%, PEA can be amazing. For other people, the inflammation is TNF alpha. Well, things like lion's mane mushroom are great for TNF alpha. But again, if instead their inflammation is IL-1 beta, then resolvins are going to make more sense. And so what the genomics does is helps you get a map. And now we do have, if you guys want to see publications, there are there are actually about 4 publications on the Intellex DNA webpage. Dr. Clearfield can send you a follow-up communication. I can give you all that information. But we have outcomes data in cognition, in autism, and now treatment-resistant mental health. At this point, the publications are mostly case studies or case series. But one of the things that I'm excited about, I went to Harvard to become a brain researcher. I quit after my master's. I was supposed to be doing a PhD, and then I went to medical school, also at Harvard, and became a family physician. But I'm a researcher at heart. And one of the things I'm very excited about is we're now involved in a number of IRB approved trials. But we already across the country have thousands of case studies. And I think that that is where root cause genomics differs from pharmacogenomics. As you talk to, we just had a conference in Austin where we had 120 of people who have been using the genomics coming for advanced training. And they'll tell you, yes, we're getting outcomes, and they're sharing their cases. So I think that the advantage is if you guys take 3 of your complicated patients that have whatever, whether it's a cognition issue, don't take severe Alzheimer's. You get too much neurodegeneration by then. But mild cognitive impairment or anxiety or depression or ADHD or patients with mystery illness, you're going to see how that you can understand that. And we had one patient who did her genomics because she was itching. No rashes. The dermatologist couldn't find anything. We were able to untangle it because of the different mast cell pathways that she had, and then figure out how to address it. But it wasn't a typical mast cell pathway. It was a regulator. So she needed resveratrol and ceramides. So again, I think you guys are going to find it really interesting. We do offer free mentoring and free training, so that even if you only order one report this whole year, you'll still get full access to our mentoring and training program, which I think you will complement well what you're doing with Dr. Clearfield. And we have a lot of longevity doctors. If you guys are in the longevity space, as Dr. Clearfield mentioned, I didn't do this talk on longevity, but happy to come back and do a talk on longevity another time.
So a long time ago, 10, 12 years ago, there was a big push for nutrigenomics. So to match food, food styles or, menu or, meal plans to genomics. And it got so complicated, I just kind of gave up.
Well, yeah, so that's a good point. So we do include nutrigenomics, and I'll speak to that on 2 fronts. We do include nutrigenomics, but I think that Nutrigenomics is actually one of the areas that you least need genomics for because many nutrients can be measured in the blood. Where you need genomics for in the nutrient world are the receptors or the transporters. So there 18% of the population do not transport B12 well into their brain. That's called TCN2. They need extra B12. Then there's also people who don't transport it into their mitochondria. They need extra B12. But in terms of the difficulty, I will say that the ease of use for genomics and has gotten much better because we've gotten better at figuring out how to present the information. So when I teach genomics, we have people first look at the hotspot. So the hotspot are the gene variants that are found in only 2 or 5 or 10 or 15% of the population. And you're going to get, even though you're going to look at 600 or 800 different variants, if you're using a broad genomics tool, you're going to have the information that you need out of their top 20 SNPs. And so we do help people go here, kind of flag what we call hotspots. So it's gotten a lot easier.
Okay. So
and then having interventions. And we also, typical dosing is another thing that we include. So not even just, and again, I didn't, because we were doing this in a CME format, didn't include screenshots, but skip over about the celiac related gene and the pesticide related gene, although it's actually this pesticide related gene makes it hard for her to metabolize pesticides, and she gets very, very anxious with exposure to pesticides. But what you'll see, she also had some mast cell related stuff, but you'll see as we get down here, anxiety comes up quite a lot, but she's somebody who did not respond or not want to even try serotonin medicines. But when we get into her anxiety report, you're going to see she has a lot of adrenaline related things. Right under in the hotspot itself, if you don't want to go into the full report, you can go, oh, okay, I have lots of things in my account. So it's going to be, I want to map this to anxiety, and I want to prescribe some ashwagandha for her. And I'm going to tell her to take that, maybe take 1 capsule first thing in the morning and repeat in afternoon if needed. So I can kind of put all this in here. By the time I'm done, I would have my whole plan. I'm going to go into the full report though, so you can see how it looks. I can load her hotspot fundamentals, which means I can at a glance go, what nutrients does she need? She needs more of that B12 and magnesium. The TCN2 is that one that doesn't allow you to transport B12 to the whole thing. I'm going to go I'll go to the report builder. I'm going to actually, I'm just going to put off all of this stuff, and I'll put anxiety towards the top so we can go look at it and show you in the whole report why we're so different. But we also have, so in her anxiety panel, I can hide the things she doesn't have, but I'm going to just show the things that are her kind of hot spots. She's got a lot of hot spots in her anxiety panel, and she's got 2 copies of CompT, which many of you may be aware of. That one is in many gene tools. But then what we do is we go, well, what does CompT do? It increases your adrenaline. Why? Because individuals with this SNP have less ability to break down the catecholamines. It takes 4 times longer, such as adrenaline, norepinephrine, and dopamine. And then if you go, what's the clinical significance? Well, it's associated with 2.4 times the risk of panic disorder. And she will tell you that when she gets worried about her kids or her significant other or things like that, somebody, not answering the phone, it creates a sense of panic. And then though, it will say, what can you do about it? So we can see that the ashwagandha that we already did for the adrenaline receptor also helps here. Now, at the same time, you can build your plan right in this report. I can talk about whatever topic, and I can say, you have very clear reasons genomically for your anxiety. And then I would go on and start talking about them, because at the end, this becomes my plan. Additionally, though, she has DIO2. You were interested in Hashimoto's. This is not Hashimoto's, but this is the ability to convert T4 to T3 in the brain. In her periphery, in terms of in her blood, her T3 is fine. But she has a benefit that makes it easier for her to convert T4 to T3 in the periphery. That's called DIO1, but she doesn't make enough T3 in her brain. You can see this is associated with a 60% increased risk of anxiety. So I'm going to add that to my anxiety action plan. We're making it so you have a neater little pick list. And I'm going to give her some liothyronine. So here you can see I could use camphorol or I could use high selenium foods, but the best evidence, most direct, would be to use liothyronine for her. And then I can say we're going to do 2 of the 5 microgram liothyronine daily. And that would be without food. And I would kind of do it before breakfast. I'll just do it at the same time. So you might try to. And then we go to BDNF. Now, BDNF is also seen in some of the nutrigenomic companies, but we're going to talk about it in more specific ways. This particular BDNF variant makes it hard to convert the precursor, the storage form of BDNF, into the mature form. And this is associated with cognitive decline as well as problems with anxiety and depression, because did you know that serotonin medicines won't work with low BDNF? And so there's lots of things we can do, but moderate to intense exercise is one of the best things. So this person was a professor, she still is, and she ultimately changed her schedule. So I'm just going to kind of go exercise so that she could go into work late a couple of mornings a week. If we were to go into other panels, you would see, I'm going to kind of unhide under mast cell. She also does have a fair amount of mast cell stuff, but there's different interventions for different genes. If she had problems with her FSAR2 pathway, you would want to avoid steroids. For FSAR1, it's not what she has, but like resveratrol directly will help to regulate an overactive FSAR1A pathway. So we're very specific. And again, this is just the mental health one. If we go into a patient with cognition issues, the cognitive report's going to be completely different. We also have a so our general medical report covers cardiac disease, diabetes, obesity, even anesthesia metabolism, macular degeneration, osteoporosis. So we have different reports. And then at the end, and this isn't going to look like much right now, when you go and you're done, you're going to have, we haven't written much yet. You'll have whatever you've written about the different topics, and then you'll have whatever you've prescribed in terms of diet, medication, supplements, and lifestyle. So you can see it's very different than most other things out there. Happy to show you other things if you have questions.
Dr. Cohen, does it include, so me being in the light of the Andrew Weil program, does the tests include any benefits for mind-body medicine or natural interventions? Because you mentioned exercise. What about meditation, breathing exercises? Is this something that's included in there?
Absolutely. So, for example, if you go into if you go into some of the potential intervention sections, I'm just going to go into the whole potential intervention. We have a detailed discussion of all the interventions. So I'm going to show you in there, and you'll see. We do supplements, but we in our autism report, we have neural stimulators, we have vagal stimulators, we have light therapy, TCMS, yoga. Absolutely, there's lots and lots of different. Dr. Lustig's 4Cs. We've got all kinds of things in here.
So it's not only for the patients to benefit this report from, but also the clinician. And I'm curious, is this something that you can integrate into EMR that easy?
So we actually don't recommend entering the whole report into the EMR. You might enter the hotspot, you might enter your summary. It does count that you could enter the patient PDF in the EMR, but a lot of patients don't want their genomics in their EMR.
Mm-hmm. Okay.
So for those of you doing hormones, I know that that's a big topic of Dr. Clearfield's. So this patient was a really fun patient. I'll just kind of show you her hotspot summary. This patient thought she was getting dementia. Her cognition was not good at all. And it was, she was fixed with basically BioT, with hormones and magnesium and some pycnogenol, because she was in the 1.4% that had huge sensitivity to hormones. So there's so many different, depending on which pathways which report you order, there's a few different reports, lots and lots of interesting information.
So one of the common used, I guess, arsenal in our toolbox are peptides. How about that one?
We are in the process of adding peptides. There are some peptides already in here. One of the problems with peptides is we only put things that are in the published literature. So we have like Selenc, we have cerebrolysin, we have certain ones, but we have to have in the published literature the evidence and the dosing. So it's a protection as well. So we do have a number of peptide doctors using this, and they are actively, we are actively adding more as we work with them. Like Dr. Crozier recently did one, so I told him he teaches peptides for A4M. I was like, give me your thoughts. We can add extra peptides when you see where we need them. So we grow as a community. We recently added the evidence for plasmalogens. So as more evidence comes out, and we can then, and for those of you who have ever heard of something called TB006, which is a new treatment for brain deterioration, for neurodegeneration, we have that. We have a whole neurodegenerative panel that supports where it's going to work. So we've got lots of things. It's a very robust.
That's True Binding. That's the newer one. I mean, it's still under IRBs, as I know, but I've been seeing a lot of good results with it. I've spoken to patients and even clinicians who've been using that. So that's definitely one to be looking out for in the horizon of Alzheimer's disease. So that also, you said it's integrated in this. You can also use that in conjunction.
I'll show you. So this is, let me kind of, I know the names, the fake names of my different patients that have given me permit. They're real people. They've given me permission to use their genomics. So this gentleman, if you want to see the neurodegenerative report.
Because that's the one focused on galectin-3.
But it has more than that. It also focuses on things relating to Parkinson's and all kinds of neurodegeneration. I have, I think, too many things open on my computer.
Because I know you need to have, I think, to need you check your genomics first before using True Binding.
We are one of the
to
tools.
Qualify that.
We are one of the approved tools for that.
All right, well, that's good.
Let's see, where did it go? There it is, right at the top. So I'll kind of pop that up and show you. Yes, and I'm happy to give you guys a talk. I did a talk at I've done a CME talk for A4M on neurodegenerative and galectin-3. I'm happy to do that for your group at some point if you'd like. So this gentleman, he was a good responder.
About October 21st.
Not October 21st, because there's a conference that I'm at, but I'd be happy to do it sometime in November or December.
All right. Hang on. November 18th.
You've got into Dr. Bill's trap.
I'm happy to do that. So this gentleman, he really doesn't, this was not where we found his main things, but like there's all kinds. Like I have a patient that she has a lot of these, tau ones. Well, there's different interventions for tau that will help to disassemble. So we have amazing genomics for cognition. Of course, we have in our cognition panel ApoE4, but we have so many other things too that other people don't have, mitochondrial issues and again, hormones. And so we give, yes, TB006 is an intervention, but you also, if you know so early on, things like modified citrus pectin can still be helpful. I have a patient with 2 copies of granulin whose father has FTD, that's more FTD related. And, for her, we have her putting trehalose in her coffee and eating a low sugar diet. We're not going to give TB006 to somebody who's cognitively intact, but she wants to help prevent. And so what this does is with all of our different tools, this gentleman's an ApoE4 and has other things, we're able to kind of filter and say, what's going to help you? And if you only can do 4 things, let's make them good 4 things. You're willing to do 10 things, let's make them a good 10 things. Does that make sense?
Yes, yes. And I encourage doing genetic testing for my patients. I mean, correct me if I'm wrong here, because I myself did one on my own blood test because it's only one. When you get one,
So
that's it.
it's a cheek
I mean,
swab, and if you
right.
did a blood test, so I would say that when you can't just encourage genomic testing, you have to know what tool you're ordering for what outcomes. So if you're looking nutrigenomics, there's a lot of choices. The reason that we made, so the name Intellex DNA comes from an intelligent approach to DNA, and my co-founder and I are women. But the reason we made Intellex DNA is there was no tool out there that looked at things like diabetes, heart disease, cognitive decline, gave the odds ratios, gave the references, gave the interventions, and had evidence for outcomes. So that's, if I sound passionate, forgive me, I don't mean to be salesy. I've been very excited because we've rescued thousands of children. Not we, mean personally, the doctors in the autism community have had thousands of children improve and even lose their diagnoses. So I feel like medicine needs to go towards a precision approach. And our mission is to help clinicians get there. So,
Right, and it's worth doing one because it wouldn't change. These are your genetics.
correct.
That's why it's not
It's a
like a
cheap
blood
swab.
test that would
It's not a
change.
blood
Yeah,
test.
every. Oh, sorry. Yeah, but blood test. A cheek swab. But that's the
Yes,
point. Genetic testing is always going to be there, and if you need it in your, like, worst case scenario situations, it's always going to be the same. So,
correct.
but one of the things that you've heard you mentioned a while ago was the Bredesen protocol. So Bredesen is kind of like the guru of Alzheimer's, right? And you mentioned that this is now integrated in that protocol. Is that
Yeah, so
correct?
I'm a co-author with Dr. Bredesen on 5 papers. So yes. So when you go to our website and you look at some of the research, you're going to
with anti-aging medicine group. I was there. Nice to see you again. I want to say, can we detect through this test any problems with the heart, such as myocarditis?
So myocarditis, there's some SNPs related. We haven't spent a lot of time building it out, but there's a lot of inflammatory, but we don't have a myocarditis panel, but we have had people use it for lots of different reasons. So you also can look at the immune system and such.
Okay, so we can see if there is a lot of inflammation in the body or
There's a lot of different
inflammatory
kinds of
pathways.
inflammation. Yeah. And
Okay.
Shell?
Okay. Well, I think you have a really exciting new paradigm. And the first thing I thought is we can invite you to speak on Dr. Halas's group, the Chronic Disease Management Group.
I
You
spoke
stealing
on it
my
a number of
speakers
years
again?
ago. You know what?
What?
Actually, I spoke to his group probably about 3 years ago, but I'm happy to speak again.
Oh, time for an update.
You stealing my
And
speakers, Shell?
yeah,
Yeah, go ahead.
so okay,
And
so what I wanted to ask, I can step back, but let's say you have a triage situation. If someone comes to you when they have a problem they're really anxious about, do you have an intuition in which way to go?
So I kind of joke, my co-founder and I joke that we can kind of talk to someone and go, oh, they're double CompT or they're NPSR1. So yes, sometimes I can kind of guess their genomics beforehand, certain genes. So there's one gene that causes high histamine and high orexin. When those people get nervous, they flush. So if you have a patient and their chest gets all flushed when they're getting nervous, you know one of their gene variants. But because we're looking at many hundreds of gene variants, you can't possibly predict their whole map. And what I want to know is I don't want to know all 400 of their gene variants, but I want someone to tell me, please give me their top 10 so I can start addressing them. And that's what
So
you
you
can
could
do.
go for a quick assessment somehow.
Right. And so you have to look at 400 to get the 10. Just because I know some of you will be having to leave, I just noticed on the webpage, the Intellex DNA webpage, if you go contact and click on that, that will also get you to where my QR code did not. You can go contact and it will give you, you can, it'll give you information. It's just going to say what country you reside in because we only sell in US, Canada, and the UK right now. And then you can submit and get scheduled to get a tour. Even if you are thinking about using Intellix DNA, it's great to have a tour because they will give you a discount code off your first couple of reports. So that's why, because they want to make sure you know how to order, how to use the tool. And so go ahead and schedule, and Christy or Wendy will be happy to give you a tour. I will
So
also
Dr. Cohen, we have a lot of foreign doctors here, especially from the Philippines. Is that something that you're going to be branching out towards to offer these services to them, or they have to go through a certain country or a company to do that, to have
So
access?
right now we are not selling in the Philippines, although there is a vendor that that's good to know that you have a lot of doctors from the Philippines, because there is a lab vendor that is working with the Philippines that is interested in adding our test. So if I think that if you're from the Philippines, email me so we can add you to our list, because when we go into a country, we are much more likely, there's certain legal things we have to do, that certain costs and such. We're much more likely to invest in a country if we have at least 10 or 15 doctors in that country that are interested. So I tell my doctors from foreign countries, let me know, because then then we know that there's enough interest.
Yeah, I think we're not going to have a problem with that. So I'm working with a huge group over there, regenerative and integrative doctors. So I think that's definitely a project that we can, I guess, huddle up with them about. And you're going to get even more than 10, 15 doctors for this great test that you have.
Yeah, so if you can email me, or you can email Carol at IntellixDNA, INTELLXXDNA. She's our CEO and she works with our legal team regarding what countries we go into, and I will let her know that that you're working. But again, if we have enough interest, then we can do the process for another country.
Yeah, if you could put that on the chat, also the email that so that we can give it to our doctors here.
I would just have them do email. I think it's just, yeah. Let me figure out where the chat is. That is not the easiest part. There it is. Okay, I think that the best thing is just to put it at info, and then Melissa will forward it to whoever with the right question. Okay, so our info is oh no, actually I think it's or support.
You did it today and I needed it. It was not.
Okay, so you could mail info or just do support. I know that support gets answered multiple times a day, and they will forward it, and I will let Carol know as well.
Great, that's great.
So, and if you want,
Yeah. So could you give us a little insight into like quality control?
yeah. So in terms, there's two levels of quality control, and somebody had a question, so I'll ask that. The quality control, there's the quality of the DNA. So we are one of the companies that not every company validates their results. So we have validated with bioinformatics to make sure that the results we report on are accurate. The way that genomics works is you don't just do one read of the gene. So to actual have quality control for like cancer genomics or pharmacogenomics, you need at least 30 reads. We have our minimum threshold of 100 reads. So you are getting high reproducibility. That's 99.98%, greater than 99.98% reproducibility. Then there's the quality control of the tool itself. So the clinical decision support tool, we do, there is a certain amount of I don't want to say guessing, but there's a certain amount of us having to evaluate the literature to decide which studies we're going to base our information on, and are they good studies. There are some metrics that you can use to do that, but what we do, I'm going to be honest, is our research team, before we add a study, we go in and look at the quality of data. And if we're looking and we're going, hey, this paper's saying this and this paper's saying this, and they seem to be contradicting, we manually go in. Our team is led. I lead a lot of it. I'm a good researcher and genomics expert, But if there's a field that is not my field, like in autism or addiction, we bring in specialists to help us kind of evaluate the literature and the quality. Do we have to change things at times? Sure, because someone might come up with a different paper might come up and we might say, we're going to take off that SNP because we don't feel like the research is as solid as we want, or we're going to take out that intervention and put in a different one. But the tool itself is very accurate. The insights have a certain amount of objectivity and a certain amount of subjectivity. Somebody asked about, said that they had signed up and they were a little overwhelmed. If they were overwhelmed, I recommend you go back to your, so obviously I can't help everyone till you get results back, and I help on the third report. But if you need more clarification, go back to either Christy or Wendy. So you'll get it when you sign up, you'll have a tour, go back to the person giving you the tour. If you did not get good results from them, please email me and I will find out who worked with you and get somebody else to work with you. And I'll put my email in there. We do have a training team, and we are in the process of adding a wonderful PharmD who is an excellent integrative physician, clinician to our team as well. So will government funding help us? You know, I think that right now government funding is a little sketchy. So we, of course, would be happy to work with any research groups. We have been approached and worked on a TBI project. And then there's questions about, can you compare with like endocalyx? There are SNPs that relate to some of those topics. We haven't done a whole study with the endocalyx people to look at if we can make it. Microvascular flow. Oh, well, you're going to get a lot of things that relate to the endocalyx, though. We're very good at blood flow. There's things there's a number of things. Okay. So please reach out. And it was great meeting all of you.
Thank you. That was fabulous.
And we'll do it again sometime in the winter on a different topic.
Okay.
Oh, I want to answer the anorexia topic. So Jennifer Craker, who is a psychiatrist in New York, who has been using our genomics for quite a while, just presented an eating disorder case at our conference. So I personally don't have experience with eating disorders, but we do have physicians using it for eating disorders. But we don't, this was more of a binge eating disorder patient. We don't have a anorexia panel per se. Some of this, though, when you address their oxidative stress, when you give them insights to the inflammation and then the things that relate to, again, one of the patients that had treatment-resistant depression and suicidality had problems with her endocannabinoid pathways. And again, PEA and omega-3s helped a lot at the right dose. So you can try it for anything. Part of it is you don't have every single disease state out there, but you're still, by addressing all these foundational things, going to have improvements.
One quick question. Does insurance cover any of this testing?
No. We will continue to do the studies needed, but it'll take a while. It'll take years before getting on insurance is not a quick thing.
It's a question about DNA results for mitochondrial health.
So some of the mitochondrial DNA are their own DNA, and some of the mitochondrial DNA is on part of the human genome. So we do have some mitochondrial related variants, but we don't have a full mitochondrial map.
Dr. Cohen, one of the common questions when people, I guess doctors, present genetic testing is that all of these genes are not going to manifest. Majority of them are more environmental stimulated or induced. So what is your stand on that specific question?
I
or
say
principle?
that is the biggest urban legend in genetics. So if you have a SNP that's in the promoter of TNF alpha that makes you make 4 to 5 times more TNF alpha, or you have a variant in the GCH1 gene that makes you make 50% less of tetrahydrobiopterin, then that's what you make. What the reason that you got that idea of, well, they might not be expressed, is the first nutrigenomics that came out was looking at homocysteine. and they looked at MTHFR and it's associated with high homocysteine. But some people didn't have high homocysteine, and they go, well, it must not be expressed. It must be because of how it's interacting with environment. And absolutely, what we eat, the different toxins we're exposed to, it can affect transcription. But if you have MTHFR C677T, you make 35% less methylfolate per variant. And the reason your homocysteine might not be high is there are also gene variants that lower homocysteine. If you don't eat a lot of protein, your homocysteine might be lower. If you have a lot of omega-3s, it might be higher. So it's not so much about that the gene might not be expressed. It might be that your diet and lifestyle already have some epigenetics that are helping you to address those gene variants. Because epigenetics just means on top. So it's the gene is the gene.
Right. So definitely it's worth getting regardless of, I mean, basically people or other practitioners gets this when people starts to have symptoms already, meaning that there's already some affectation towards the gene expression. But from the sound of it, really finding it out from the get-go definitely will be a better approach.
Absolutely. We have a huge group of doctors that use it routinely in their practice just as part of their concierge practice. And that's what makes their practice different. It's a precision medicine practice. We have longevity doctors, and then we have people that work with complex pediatrics or complex illness where everybody's sick. So, but there's, ultimately, I believe that if we were to flash forward 30, 40, 50 years, people will be getting their genomes swabbed and interpreted as infants because, but you have to kind of think about the ethics of how do we only talk about the gene variants and make sure people understand that this is not your destiny, that gene variants can be modulated when you understand the variant. And so ApoE4 is not a causative effect of Alzheimer's. I have an ApoE4 patient who is 82 years old in the 95th percentile for cognition. So it depends on what the ApoE4 is found in combination with and also how you address it.
Thank you. Awesome talk. I wish we could get some more of you, but I'm sure you have other things to do.
Well, we have live conferences every year, and I will make sure that Dr. Clearfield knows.
What conferences do you have coming up in the fall?
Well, I will be at the Integrative Mental Health. I'm at IMMH is September 11th in San Diego. I will be at the Integrative it's ICIM, which is the Integrative something in integrative medicine. I forget the initials. That's going to be in Atlanta, August 21st. I'll be at MAPS September 4th through 6th. So those are some concierge medicine is a conference for doctors wanting to do concierge practices. That's also in Atlanta in October. So those are some of the ones in the next couple months.
Okay, well, keep us informed with all of your exploits. So
thanks. And remember, you can have 20 hours of me on Genomics University anytime you want. So, and there's a lot of ones on our website as well.
Okay.
Take care.
Genomics University. Okay. Thank you so much for being here. We really appreciate it.
You're welcome. Sorry about that little bit of difficulty getting on.
That's okay. No problem. I have you penciled in for, where did I put you? November 18th, but I'll just have you penciled in, but I'll catch you later. Okay. Thank you so much.
Okay. Take care. You're welcome. Bye-bye.
Okay. Dr. Nario, got anything to wrap up here?
No, again, that's a lot of debunking of what we thought DNA testing is all about. So as you can see here, I thought you should only use it as a last line of defense. But as you can see, as a first line, it will save you a lot of money, save you a lot of time, and even finding out more specific problems for the patients before even trying to cross out anything off that list that you have. So I highly agree with what Dr. Sharon said. So, but of course, again, cost is always going to be one of the clinical obstacles
the problem
here.
Is, hi, Dr. Nario, I want to come see you. I have X, Y, and Z. And the first thing you tell me, well, it's $400 to talk to me.
Right.
I want a $900 DNA test. Then I need, a $500 worth of serum lab tests. It kind of adds up, right? and
yeah.
I don't know how anybody out there who does this concierge medicine where you pay $2.99 a month or $90 a month. I just can't figure out. I've never been able to figure it out myself how to make that work. What's included, what's not included, that kind of thing. Maybe we ought to find
But I
some.
think
I know.
yeah, you really have to find the population
I
for it.
know Stefan does it, but he's got like that medical gym that he runs and things like that. So
There's
oh,
a
you're still
lot of
here.
different ways. Yeah,
We're talking
I was just about,
we're trying to
there's a
talk
lot of
behind your
ways of
back.
different models. But I do want to say that when you use genomics, you would not order a bunch of lab tests at the same time. You would get the genomics back, address them, see if the genomics kind of pointed towards, like if you have really, really bad toxin pathways, you might check for toxin levels. If you have really bad immune pathways, there's some things that make it so you can't fight off for certain infections, you might look for them. But in terms of the different models, if you do end up using our genomics and have questions as to how to use, how to kind of do the business models, our director of growth will be happy to share with you what different models across the country. But I think in the long run, because integrative and functional medicine physicians charge either by the hour or by the year, if you can get patients better more quickly, you still end up saving patients money.
And I
Because
think part
especially,
of your training, right, is how clinicians can integrate this in their actually business
yes,
part of their practice. So,
yes,
and not only the
absolutely.
clinical side do you have to offer
We
for
do.
us practitioners.
We do have business people that can help with that because we never planned on telling you how to run business, but Carol, my co-founder, and I, we actually teach at Concierge Medicine about running practices and different practice models and making a successful practice that is of value even after you choose to retire. So there are people on our team who've taken the knowledge and experience from all of our hundreds and hundreds of doctors, and are happy to share different models that have worked with you. So
Okay.
this time I'm really leaving because I have a talk to
I know,
tomorrow.
I know it's kind of late, but there's a late question here about methyl issues and hypomethylating agents. I don't know. Do you have anything on that?
Well, I mean, I think that that's kind of what we were talking about before. People think about, oh, MTHFR and methylation is such an important issue. And what I say to that is the one copy of MTHFR is in 45% of the population, two copies is in 14%. It's one gene out of 26,000. And so being able to convert folate into methylfolate is important. Methylfolate is not even the main methylator for our body. Methionine is. So there's a lot of urban legend, and the exciting thing is when you study genomics, all of a sudden you're going to feel like pathophysiology is so much more meaningful. You understand, why does someone get migraines? Why does somebody get heart attacks? Why does somebody get strokes, cognitive decline? Because you're looking at diabetes, whatever it is, because you're looking at the root cause and you realize each gene is a small component. It's the sum, and then some people have some genes that are really important, but a lot of these popular genes are one piece of the puzzle.
May I interject? That was my question. Sorry, no
Sure.
shame. Hi, good evening. Um, and I'm Joni. I don't even know if you can see my head in here. Hi. My mom has just had bone marrow transplant, and what was fascinating to me from an epigenetic genetic standpoint was that in her genome testing, she showed that she had, MTHFR component, and she's had issues always with her methyl factors. She's been on methylfolate, all of that jazz, right? But then her treatment for the chemo agent was a hypomethylating agent. So I asked the oncology doc, I said, wait a second, so help me understand this.
Oh,
So,
it's to kill the rapidly dividing cells. Yeah. So
right, but I wonder if there's any association of the two.
so not so much MTHFR, but that is one of the reasons that in an adult you have to be careful with SAMI, because SAMI methylates everything, but over methylation can contribute to certain kinds of cancers as well. But they have not shown that methylfolate contributes to cancer.
Because we never addressed that about overmethylating because we're so hypo. You know what I'm saying? So I think that would be
Right.
interesting.
And it's all really, so here's the thing. We have my favorite saying is genomics is hard. But that's because the human body is hard. And so you take one piece at a time and you try to understand each individual. But the reason, if cancers are rapidly dividing cells, and so if you disrupt so methylation is very much involved in DNA repair. So if you disrupt, the reason they use hypomethylating agents is they want to get rid of any fast DNA replication. So it's a little bit related to genomics, but it more has to do with let's get rid of fast dividing cells.
Makes sense. Thank you. And by the way, do you see pediatrics at all? Do you do consults for
I
pediatrics?
hardly see patients anymore, but I'm happy. What state are you looking for a pediatric person in?
Florida or Georgia?
So a number of amazing people. I would recommend Dr. Danette Calais, Kallay. She has an online practice as well as brick and mortar in Georgia, and she has Florida and Georgia license. So, but you can go to our website and put in any state. But with pediatrics, if you're interested in pediatrics, there's also the MAPS conference, September 4th through 7th. Their whole plenary session this time is on genomics. So you'll meet tons of people who've been using genomics in practice. And MAPS, even though it's the Medical Academy of Pediatric Special Needs, has expanded to pediatrics and special needs so that they are doing adult medicine as well. Great
Fantastic.
place to learn.
Thank you so much. Thank you all. Sorry for interrupting.
You're welcome.
Thank you.
And I have a code if anyone wants to go you can put in INTELL 2025 and get 20% off.
Oh,
okay.
nice.
Okay. Somebody asked about the ICIM conference in Atlanta. It's August 21st to 23rd. And then I did get the CME link. It's in the chat there, and the number is 11367.
Yes, that is absolutely a CME conference. All these ones that I'm speaking at are CME. So you get lots of opportunities.
The last link there, that's the CME for tonight. That's the
okay.
Folks who want it. Okay. So for tonight, you get 2 credits for $50. So, okay.
Well, nice to meet all of you.
Nice to meet you again. Thank you so much. This was really fabulous. And this is kind of what we do. We've been here since 2020. We're here every Tuesday night. And sometimes we have great speakers, and sometimes we have really great speakers. And then when we don't have anybody, we can't find anybody, they get me. And
well, I'm happy to give you a list of some people who are.
That's if Dr. Nario is busy with the Andrew Weil. We're trying to get him too. I'm going to get him by the beard and get him here. So
I can give you guys. So Dr. Nario, are you in the Philippines? Is that why you said that?
No, I'm here. I'm in the US.
Okay.
So
I'm happy to give you names of great speakers, Bill, because we just had a live conference and I had 12 really great faculty come in and speak at it. So.
All right.
Yeah, bring them in. We're pretty open.
Bring them in. I have endless Tuesdays as long as we keep this going.
That's great. Nice to talk to you guys. Take care.
Thank you so much. All right. Anybody else have any comments, questions? Any of the research guys still on? Dr. Quinn, you around?
I'm around. I'm still here.
Must not be too hot in Las Vegas. You have a shirt on.
Yeah, doing well. Hey, first of all, that was fantastic. I'm going to give a shameless plug here with our products. You guys know she was talking about that patient with endocannabinoids.